Hello everyone, welcome to MRCOG Part 2 July 2026 Lessons Learned. So today we are going to talk about a very interesting and important topic, what actually July 2026 paper taught us so that we can effectively analyze and plan a strategy for January 2027. That is the main purpose of doing this session. I know the results has just come out. Many of you have crossed, some have not, and many are starting now their journey. And everybody wants to do this in one go, and that is what the motive is also, because first attempt is the best attempt. So if you are planning for the first time, choose the right path and go ahead. Secondly, if at all you have, unfortunately, you have to repeat the exam, please don't get disheartened. The exam is such that it tests you intensively. So better is keep going, because that is the way you are going to get to your destination. So here I come to my topic back, that is July 2026 lessons learned. So here we are going to talk about three main things: where the marks were, second, some questions we will be talking about, and why actually candidates lose this exam. So, first we are going to analyze what were the important topics here, followed by I will be taking some questions, and I will really love to have the answers in the chat box so you all can respond there when we take up the questions. And also you are welcome to leave your queries on also on the chat box. I'll be happy to answer those queries as well. And finally we'll talk about what is the difference between a pass fail and the fail behavior. Although I totally believe that it is just one day performance, one day cricket match, you may be doing very good, but at the last moment you just got confused, or maybe something went wrong, and this all happened. So, no hard feelings for anyone. It's just about like we are here to make ourselves better every day. So, if at all I'm stuck here, then maybe this is an opportunity for me to do better. So, taking this in mind, I'm starting with the first point. First point, that is, what is the distribution of the marks? What were the main modules which were the most scoring ones? And then we will also look at what were the topics, because I want to tell you repeatedly that it's not about reading more and more and more and more, increasing your syllabus, but it is always about picking up the right topics and reading them as thoroughly as you can, because the thorough reading is must. So topic distribution, July, from the July 2026. So, as you see, the maximum part of the paper, 16% paper was see, these are the approximate numbers. I don't have any paper from which I can say that this is there, but this is what the approximate number is. Maternal medicine was almost 16% of the paper. So now you see how important maternal medicine is. 16%, huge paper, followed by the urogyne and prolapse, followed by menopause and HRT. So these three topics actually made up the topmost part in this particular intake. So epilepsy, hyperemesis, IBD, TB, thyroid, diabetes, cardiac, VT, all important topics. Simultaneously, the sexual health module. This time there were plenty of questions about the antibiotics, their dosages, their durations, and with a small difference between various options. So it was very important to know everything in detail. It's not about knowing that this is the infection and this is going to be the antibiotic. You need to go into the details. So 12% was from the sexual health module. Urogyne and prolapse still constituted 10%, making it next important module. Gyne, onco, and vulva. Vulva has always been a favorite of RCOG. without doing these common topics like vulva and all, it is very difficult to pass. So let's practice these topics more. Yeah, hello. Yes, I can see many of my lovely students have joined. Yes, Dr. Sabi, Dr. Shabnam. Yes, Dr. Ligi. So, good evening. So, here I was talking about the marks distribution. Then, the next was the menopause and HRT. And see, this fezolinetant is the new drug. It was the new drug. And, when I was just going through, we were discussing the menopause questions in the class. I just told my students that this is the new drug and you can just remember this. Maybe in the new questions which come in exam, maybe you can have this one. And I was so happy to know that most of the students, they told me like, ma'am, oh, it was the first one I see. And just made me relaxed. Okay, I know this answer. And that gave me the further confidence to go more forward. So that is why the recent advances, what is going around, you need to keep tab of like what RCOG is talking about, what RCOG is thinking, because the questions are going to come around that as well. 9% from the fetal medicine. Fetal medicine is always very important. You can overlap this with the antenatal module because FGR, Dopplers, if I say it is also part of the antenatal module. Polyhydramnios, cystic hygroma, twins. So again, this is lot of fetal medicine and antenatal care module as well. Labor and delivery, as always, is important with 8% questions from this topic. But the good thing is, more or less, the scenarios about the labor, they are like overall going to be almost close to what always come. So if you know that much kind of scenarios, it is easy to go. Early pregnancy, 7%. And this is one module, and I think so fertility. My students easily score 100% in this, and that's where actually you can pick up marks in the easy modules. Early pregnancy questions are very much fixed. If you know them thoroughly, you can gain easily 100%. Then coming to ethics, law, and governance. This is very important subject, and nobody can skip this basically. So it is very important to go through this. Statistics, AI, evidence-based medicine. AI-related questions were new because there was a TOG article, so it was based on that. Fertility and the reproductive endocrinology, as I said, this is always a very important. Sepsis and critical care. Few questions are definitely going to come from this. Now, if you look at this thing, then almost like if you look at this, almost 12 topics. If you know these 12 things, you know everything, right? You know everything because there that is from the paper is coming from. 40% of the paper, if you look at, came from the menopause HRT, maternal medicine, gynaecology, and the sexual health combined. So this, even if like you are firm, you are thorough with these repeatedly asked topics, you can still have very good chance of clearing your exam with adequate marks which are required to pass. Now, the one thing what has changed, the recent guidance was overrepresented. In part 3, it always used to be there, whatever recent advances are there, many of certainly some stations used to come from. But now in part 2, part 1, also the same thing is there. So this has definitely been there. So over-representation of the recent changes or the recent update was seen here. Like the numbers from the impacted fetal head SIP, SGA and fetal growth restriction guideline, then, as I mentioned, fezolinetant, that is NK3 antagonist, then AI randomics and exosomes, virtual reality analgesia, which was also important a question there in the exam, and then unscheduled bleeding of HRT, which was also 2024 guideline and still one of the favorite of RCOG. So, for every core topic, know what changed in last 24 months. Examiners write from what they have just read. So very, very important to follow what is changing in RCOG, what is getting updated. You need to get updated, that's why. So that is why like we keep on updating. Like currently we have totally updated the subfertility module because the NICE guideline and the OHSS, both of the important sources have updated. So that is what we were talking about. Now, so finally, what was the main thing, highlight of this paper? The signature of this paper was precision over recognition. Means it is not just important to understand that this particular word is the answer, but it is also important to know that the precision, what is the precise thing which happened. In question after question, all five options named the correct concept. They differed only by dose, route, frequency, duration, or interval. So, overall, that is what it is, like all options, and these are specifically like they mean by this. And you just not know that this particular antibiotic is to be given, but you need to know what is the exact dosaging, when is to be given. So those details were more important. So the topics covered were still the same, but as we are going further, the depth of the topics is increasing. And that is what we need to do. Like if I talk about the dose, there may be multiple options with 100 milligram, 200 milligram, 300. Duration is like UTI 3 days, 7 days. So that also is increasing. Intervals is surveillance 4 to 6 weeks versus 4 to 6 months. Route is oral versus vaginal by misoprostol. Direction agonist versus antagonist. So these are there. The questions. 8 single best answers and the 5 extended matching questions which we are going to talk today. Now here, single best answer. Let's take this and I will be happy to have the answers in the chat box. Please be ready and we'll be seeing who is going to answer first. And I'm going to pronounce that name. Whoever is going to answer first for any particular question. So let's start the questions. 27-year-old woman is brought to the emergency department 4 days after a home birth. She reports offensive lochia and rigors. On assessment, temperature is 38.9 degrees centigrade. Heart rate is 126 beats per minute. Respiratory rate is 26 per minute and blood pressure is 86 by 48. Oxygen saturation is 93% on air and venous lactate is 3.4. Blood cultures have been taken, urine output is being measured, and intravenous broad spectrum antibiotics have been prescribed. Which of the following completes her immediate management? So, what exactly here is happening? So, if you look at the vitals and the lactate, you know that this is a septic shock. So, now the management has everything very close to that. But I'm looking for one best answer. See who is answering. One best answer I would like to see. So yes, that's Dr. Sabi B, D, okay, B and D. Okay. What else? Yes. Only three people answering. Please try everybody. Everybody, please try answering. Okay. So now this is the thing. Like we need to know exactly what oxygen and what fluids. Okay. Yes, Dr. Ruza, that's the correct answer. C is the correct answer. I was looking for one correct answer, and yes, Dr. Ruza has given that correct answer. Oxygen is 15 liters per minute. So it is important to know, again, I said that we know that oxygen is to be given, fluids to be given, antibiotics to be given, but what? What exactly, how much amount, what is the dose? That is the important in-depth knowledge. So oxygen 15 liters per minute via reservoir mask and 500 ml crystalloid stat. So oxygen 15 liters per minute via the reservoir marks and 500 ml crystalloid stat. The sepsis 6 must be completed within 1 hour of recognition. The STEM has already given you 3 of the 6. So the question is testing the other 3. High flow oxygen via reservoir targeting saturation of 94 to 98%. A simple mask at 10 liters per minute does not deliver an adequate FiO2 in shock. So you need 500 ml crystalloids over less than 15 minutes, repeated to a maximum of 30 ml per kg. That is what is required. So unless and until, just by knowing that oxygen in the fluid is required is not enough. You need exact number and the exact speed to score marks on this. Coming to the next question, let's see who answers this correct. So here it is 30-year-old woman is reviewed on day 2 postnatal. She has focal epilepsy and takes lamotrigine. Her dose was increased from 200 milligram twice daily pre-pregnancy to 400 milligram twice daily during the third trimester, and she has remained seizure-free. Today, she reports drowsiness, unsteadiness, and intermittent double vision. She is breastfeeding. What is the most appropriate management? Now, what is happening here in this case? So, in this case, patient has delivered and she has the history of focal epilepsy, so she was on lamotrigine. But now she is having drowsiness, unsteadiness. So now what is happening? Basically in pregnancy, she required the higher dosages. So now in after delivery, the clearance is back. So now the unsteadiness, the drowsiness, unsteadiness, and intermittent double vision, she is breastfeeding. So now it's the time to decrease the dose. To decrease the dose, to bring the dose back to the pre-pregnancy level. So now that is what we know, that is something like this has to be done. Now, if you look at the options, they are confusing. Either you reduce to the pre-pregnancy dose and then check the lamotrigine level, or you check a lamotrigine level and reduce the dose. There are two options, okay? I can see the D and C option in the chat box. Anybody wants to give another option? Anybody wants to give another option? So basically, in this case, because the patient is symptomatic, right? She is symptomatic, drowsiness, unsteadiness is there. So we cannot wait for the levels to come. We need to decrease the dose at the moment and then we can check the levels. So in this particular case, B is the correct answer. Yes. So Dr. Saida, yeah, that's the correct answer. No, we cannot stop in the breastfeeding because patient is stable on that particular drug. So we cannot immediately stop. And rather in this case, basically, we need to go back to the pre-pregnancy levels and then we can check the option. Okay, there was another option. You can write it down, Dr. Sabi. If you can write it down, we'll get to know what is the other option. So basically reduce to her pre-pregnancy dose now and check a lamotrigine level. Refer to the neurophysician for dose adjustment. Okay, if that was the option, that is the best one. Because refer to neurophysician is very, very important in this case because that will also help rule out any neurological disorders. So always, if it is about referring to the specialist, that is always going to be the best management here because the specialist reference will rule out other neurological causes of drowsiness and then this in the pregnancy as well. Changing lamotrigine can be harmful for baby. No, see, evidence says that if like you have to weigh between the risks and benefits, then the benefits are more. 31-year-old woman with rheumatoid arthritis is seen at 16 weeks gestation. Her disease has been well controlled on etanercept for 2 years and she has had no flares. She asks how long she can continue her treatment. What is the most appropriate advice? Now let's see who is going to answer this question. So 31-year-old woman with rheumatoid arthritis is seen at 16 weeks gestation. Her disease has been well controlled on etanercept for 2 years and she has had no flares. She asks how long she can continue her treatment. What is the most appropriate advice? So here, what you need to do? For etanercept. Yes, I'm waiting for the correct answer. Who is going to answer? Let's see. Nobody? Nobody? So here basically continue until the end of second trimester. Usually we can stop in the beginning of the third trimester between 30 to 34 weeks, right? So between 30 to 34 weeks we can start. So here B is the closest answer. Continue until the end of the second trimester, then stop. Why? Because if the patient has stable, then we can stop at this point. Because if we continue beyond this point, then baby cannot take up any live attenuated vaccine for first 6 months. So we need to see whether patient needs this till the complete pregnancy and puerperium or not. Continue until the end of the second trimester, then stop. Etanercept and adalimumab may be continued to the end of second trimester when avoided in third trimester so that cord blood levels to the delivery are low or absent. Infliximab is stopped at 16 weeks. Cetrolizumab is the one which is compatible with all three trimesters. So infliximab stopped early. Rest we can take up to the beginning of third trimester when we stop so that the baby is not affected. Okay. So good. Finally, I got the B answer. So Dr. Sabi was the first to answer the B. So a round of applause for Dr. Sabi as well. So here we go on to the next question. 26-year-old woman in her second pregnancy has anti-K antibodies detected on her booking antibody screen at 16 weeks. At the titer of 1 in 8, her partner is K positive and heterozygous. Her first pregnancy was uncomplicated. And what is the most appropriate management? So 26-year-old woman in her second pregnancy has anti-K antibodies. Yes, perfect. Dr. Saida Nagma, very good. C option, refer to fetal medicine now for fetal K genotyping. This is very, very, very important because for K, we do not have any such levels. If they are present, then only we have to refer to fetal medicine unit. So that is the correct answer here. Very good. You are consenting. Yes, Dr. Shabnam, you are also right. C is correct answer. You are consenting a woman for an unplanned cesarean birth at full dilatation. She asks about the risk of the baby's head becoming stuck. Impacted fetal head complicates approximately what proportion of unplanned cesarean births? You are consenting a woman for an unplanned cesarean birth at full dilatation. She asks about the risk of the baby's head becoming stuck. Impacted fetal head complicates approximately what proportion of the unplanned cesarean births? So let's look at this. Okay. 1 in 10. Very good. Dr. Deepti is the first correct answer. Dr. Saida, Dr. Shabnam. So everyone very correct. It is 1 in 10. Impacted fetal head complicates up to 1 in 10 unplanned cesarean births, equivalent to about 1.5% of all births. Now, there is another figure which is also very important. 1 in 3 cesarean births at full dilatation may be complicated by impacted fetal birth. So you have to take care what is the denominator. If it is the emergency cesarean section, then the answer is 1, that is 1 in 10. But if the denominator is the impacted fetal head in full dilatation, in full dilatation cesarean sections, then answer is going to be 1 in 3. So very carefully you need to know this. Okay. Another good question here. 68-year-old woman has urgency, frequency, and urge incontinence. She has completed 8 weeks of supervised bladder training with no improvement. She underwent laser iridotomy for acute angle closure glaucoma 3 months ago. Blood pressure is 128/78. She has no other comorbidity. What is the most appropriate next step? 68-year-old woman has urgency, frequency, and urge incontinence. She has completed 8 weeks of supervised bladder training with no improvement. She underwent laser iridotomy for acute angle closure glaucoma 3 months ago. Blood pressure is 128 by 78 and she has no other comorbidity. What is the most appropriate next step here? Now, because the acute angle closure glaucoma is there, so basically this is not not suitable patient for the not suitable patient for the anticholinergics, and so mirabegron is the correct drug here. So yes, that's good. Dr. Shabnam, Dr. Rohita, yes, very good. So mirabegron 50 milligram once a day is the correct answer. Antimuscarinics are contraindicated or for use with caution in acute angle glaucoma. So mirabegron is the appropriate first drug here and it can be used. Okay, moving on to next question. 65-year-old asymptomatic woman undergoes CT for cholecystitis. This shows an incidental unilateral right ovarian cyst measuring 3.8 into 3.5 into 4 centimeter. Subsequent transvaginal ultrasound confirms a simple unilocular and echoic cyst with no septations, no solid components, and no primary projection, papillary projections or ascites. Serum CA125 is 20. What is the most appropriate management here? So she has a incidental unilateral simple cyst, which is 3.8 into 3.5 into 4 centimeters. So what needs to be done for this patient? What is the most appropriate management plan? Yes, what is the most appropriate management plan? Looking for the answer. Discharge, no follow-up. No, that's not correct because it is only up to 3 centimeter, right? Yes, C is correct answer. Repeat ultrasound and CA125 in 4 to 6 months. Yes, Dr. Deepti is the first correct answer. Nice, nice, nice. I think Dr. Rohita also gave the correct answer. So Dr. Rohita, Dr. Deepti, yes, it is not nothing discharge because nothing discharge is only up to 3 centimeter. Here it is more than 3 centimeter. And because more than 3 centimeter, so review in 4 to 6 months is the correct answer here. Okay. This was something which was actually from the part 1, but this time came into part 2. The study evaluates a new ultrasound-based model for distinguishing benign from the malignant adenic cell masses. The receiver operating characteristic analysis reports an area under the curve of 0.947. How should this discriminatory performance be described? So the receiver operating characteristic analysis reports an area under the curve of 0.947. How should this discriminatory performance be described? So it is basically how do we take this number? That is the correct answer here. So this number actually goes by the excellent because 0.5 when we take 0.5 when we take, that is something which just happens like random. You did a toss, you got head or tail, that is just a random thing. And 1 is the perfect discrimination. Between these two, you have various categories. 2.5 to 0.6 is fail. 0.6 to 0.7 is poor. 0.7 to 0.8 is 0.7 to 0.8 is fair, 0.8 to 0.9 is good, and 1 is excellent. So this is how the things are. So when we are looking at this is basically the 0.5 fail, and as you move towards the 1, that is excellent. So here it was 0.9, so it was excellent, and the correct answer was given first by the Dr. Rohita, then Dr. Deepti and Dr. Shabnam. They all got the correct answers. Now let's practice some EMQs as well, because EMQs is the main pain point. So we should work on that as well. So here is the EMQ stem for you all. 24-year-old woman attends a sexual assault referral center 18 hours after vaginal penetrative assault by a stranger. She has never been vaccinated against hepatitis B. The assailant has not been identified and his hepatitis B status is unknown. 24-year-old woman attends a sexual assault referral center 18 hours after vaginal penetrative assault by a stranger, and she has never been vaccinated for hepatitis B. Now, this is something which is basically talking about a sexual assault case and the risk of hepatitis B. So, what needs to be done in this particular patient? We don't know what is the assailant's hepatitis B status. It is unknown. So what needs to be done for this particular patient? Let's look at all the options. So either we need to give the immunoglobulin alone or immunoglobulin with accelerated vaccine, accelerated HPV vaccine alone. So yes, we need the immunoglobulins plus the accelerated vaccine. That is the correct answer here. So B is the correct answer. Dr. Deepti, Dr. Rohita, very good, very good. Now coming to the next. The ST5 sustains a needle stick injury from a suture needle while closing the uterus at cesarean section. The woman's booking virology has not yet been reviewed. What is the immediate first step? Now, this patient's status is not known, but the needle prick is there. What is the immediate first step? Immediate first step. Immediate first step. They are just asking about the immediate first step. So let's see who is going to give the correct answer here. Immediate first step is washing the wound with the water. Wash the wound with water and do a risk assessment and the occupational health. Yes, I is the correct answer. Dr. Afroz, Dr. Deepti, yes, correct answer. Very good. A neonate is born at 39 weeks of vaginal birth. The mother started combination antiretroviral therapy at 22 weeks. Her HIV viral load was 320 copies per ml at 28 weeks, 180 at 32 weeks, and 90 copies per ml at 36 weeks. She will formula feed. She will formula feed. A neonate is born at 39 weeks of vaginal birth. The mother started combination antiretroviral therapy at 22 weeks. Her HIV viral load was 320 copies per ml at 28 weeks, 180 at 32, and 90 copies per ml at 36. She will formula feed. So what is happening around here? So because at 36 weeks, she is still carrying the 90 copies. So the combination therapy is still not effective in her case. So baby is at risk. So what we need to do? Yes, G is the correct answer. Perfect. That is perfect. Yes, G is the correct answer. Yes. So for G as the correct answer, zidovudine and lamivudine for 4 weeks and nevirapine for 2 weeks is the correct answer here. So as we read, whenever the unknown B status and there is a risk, stranger risk is high, we need to go for the accelerated B vaccine. Then, and the vaccine alone is enough. We do not need immunoglobulins here because we do not know the status. Then wash the site under the running water, then risk assess and refer to occupational health. Zidovudine and the lamivudine for 4 weeks with nevirapine for 2 weeks. That is the correct answer for the third step. So while we are going through this, another 3 questions set for this, particularly from the genitourinary medicine, because that was also one of the important topics in exam. So a 28-year-old primary gravida at 14 weeks gestation has dysuria and frequency, and her BMI is 52. Urine culture grows is E. coli sensitive to nitrofurantoin, trimethoprim, and cephalexin. Her EGFR is normal and she has no allergies. Now, what is to be done here? She is sensitive to nitrofurantoin, trimethoprim, and cephalexin, and she is in the initial 14 weeks. So, what can we do for her? Yes, nitrofurantoin is a good drug. We can continue that drug in her case. So nitrofurantoin dose will be 200 milligram BD 7 days. Yes, Dr. Rohita, fastest finger first. You got it right. So C is the correct answer here. 24-year-old woman at 8 weeks gestation has a positive NAT, that is nucleic acid amplification test, for chlamydia trachomatis on vulvovaginal swabs. She is asymptomatic and has no drug allergies. So what happens in chlamydia in pregnancy? So chlamydia in pregnancy is going to be azithromycin. Azithromycin, and 1 day is not enough. You need to give 3 days. Doxy is another drug which can be used, but patient is pregnant. So we cannot use doxy here. We'll stick to azithromycin 1 gram and then 500 milligram into 2. Now, the 30-year-old woman at 34 weeks gestation is found to have a single painless vulval ulcer. Treponemal serology is positive and she is diagnosed with primary syphilis. She has no penicillin allergy. 30-year-old woman at 34 weeks gestation is found to have a single painless vulval ulcer. Treponemal serology is positive and this is actually primary syphilis. She has no penicillin allergy. So now in this case, we need to give we know that for syphilis, the best drug is the benzathine penicillin, but we need to know what is the correct dose here. So benzathine penicillin in 3 weekly, or 2 times, sorry, not 3 weekly, it is day 1 and day 8 is the correct answer. So 2 dosages you are giving. So H is the correct answer here. Yes, as Dr. Rohita mentioned. So nitrofurantoin modified release 100 milligram twice daily for 7 days. Azithromycin 1 gram orally, then 500 milligram once daily for 2 days. Benzathine penicillin 2.4 million units intramuscularly on day 1 and day 8. These are the correct answers to these questions. Finally, coming to the part 3, why good candidates also sometimes fail, which is very, very unfortunate because you all have worked so hard. There are certain things, 6 patterns that cost the marks. One is concept without number. If you are not sure about the number, but you know that what is the concept, that can actually make you lag behind. Going with the older guidelines and not focusing on what are the updates, that is what is also affecting. Gynecology left until last. Sometimes we think that some topics we have read initially and we keep on postponing. So we need to focus like exactly what is important and keep on repeating that so that we are good to go with that. Over treatment as a default. No, you have to specifically go by the rules. Never think about like what you can do in this case. Ethics treated as soft marks. Ethics are very important. You should be very thorough with the ethics questions. Reading the stem, not the lead in. So initial step, next step, most appropriate definitive management, first investigation, exactly question is asking what, accordingly you need to answer. So you can build your own number sheet. Whatever you are learning, try to write from your active recall rather than making the notes. Focus on writing it from your brain memory, the numbers which you can remember. So 8-point technique checklist, how you can do this. Read the lead in before the stem. Carefully see what is asked in the question. Justify every number in the stem. What all things? They are asking you multiple things in one question only. So for that also justify what exactly is required. Budget 60 seconds and never leave a blank. So there is no negative marking. So try to address them and do not keep off overthinking because overthinking also brings it back. Answer according to, of course, the RCOG guidelines. Answer before you read the options. And first think about the answer and then look at the options. Or on those questions, eliminate on the number. In EMQs, read the option list first. Treat statistics and ethics as free marks. So statistics and ethics need special attention. So these 8 things, if you do, you have a good probability to pass this exam. So rank your topics. See that where actually you are losing marks. Start the number sheet, then start picking up like what are the concepts asked from those particular topics and try writing them from your memory recall. Check the updates, what all are is getting updated, and try doing questions every day with time. So like 40 questions timed you are doing every day. And this is how you are building the stamina also, because part 2 you need that stamina also to do the questions. Where to go from here? So you can either go for a structured part 2 course, which can help you practice questions like this daily, or you can choose the verified question bank, but it should be the correct questions with the correct answers. Recon analysis sessions. This session, every sitting free on the YouTube. So this session will be uploaded here as well, and you can always watch it. If you want to talk to me about something, discuss your exam preparation, then this is the calendar link which you can scan and book a meeting with me, and the phone numbers I mentioned on which you can make a call. Hope you all enjoyed the session. Any feedback, any questions, where you want to talk about, you are welcome. You are welcome to talk about the questions. Yes, anything. Hope you all enjoyed the session. Bye bye. Have a nice evening ahead. And we'll meet again in the next live session. And if any particular thing you think we need to cover in the live session, do mention that in the chat below, and I will be taking that as well. Okay, bye bye. Take care. Bye. Thank you. Thank you, Dr. Rohita. What to do with questions? Yeah, so basically you have to pick up the questions which are of good quality, then time yourself. Start doing the questions, keep a paper pen aside and write the points from your brain. That is what is required to properly recall the things. But you need to practice questions and increase your practice, grow from 30 to 60, 60 to 90. This is what you need to do. Thank you, Dr. Shabnam. Thank you. Yes, Dr. Sabi. If the range is given in GTG, all ranges are present in answer. Yes. So usually if the range is given in GTG, we go for the higher one. You try to be figuring out what is the nearest one to that. So, Dr. Rita, connecting with you, Bosa model. Thank you so much. Yes, Dr. Chandula, Suresh. Thank you, thank you, thank you. Thank you everyone for joining. Bye bye. Take care. I'll do again another live session and then we'll meet again as well. Bye bye.